Yeah, go ahead.
All right. Sorry, this is going to be on my phone, so it's going to be a little bit of a awkward experience. Thanks to everyone for bearing with me. So I'm going to talk on health inequities and allergy and immunology with a focus on asthma. I have no financial disclosures. And the word of the day is equity for those that are getting CME. All right. Let's move this thing out of there. Okay. So I want to start off with a land acknowledgement. So here you'll see a photograph of Chief Seattle, also known as Chief Seattle, and this is from 1964. And
No,
I just want to acknowledge,
1864.
sorry, 1864. Yeah, that would have been not long enough.
Right.
Um, and I would like to acknowledge that we are on the traditional lands of the Coast Salish people, including the Squamish, Tulalip, Duwamish, and Muckleshoot nations, the first people of Seattle, past and present. I also would like to express gratitude for this land itself and honor the ancient heritage of the Coast Salish peoples who continue to be with us today. All right, and I also want to acknowledge that this country would not exist or prosper if it were not for the labor of enslaved Black people. I honor the legacy of the African diaspora and the Black lives, knowledge, and skills stolen into violence and systemic oppression. These were taken from Seattle Children's Health Equity Rounds. All right, so this is just a brief collage. I'll skip through this, but this is I'd like to go through this every presentation just so people get to know me a little bit better, for those that may not know me already. All right, so for the first learning objective, it'll be recognizing the root causes of health inequities and allergy and immunology. And much of my talk is founded on this work group report by the American Academy of Allergy, Asthma, and Immunology, Health Disparities in Allergic and Immunology Conditions in Racial and Ethnic Underserved Populations. I would recommend that if anyone wants to learn more, that they go ahead and look at this document closely. So to start off, just thinking about what is health equity. So some of you may have thoughts. If you are interested or would like to participate, I'd like to hear if anyone wants to shout out what they think health equity is, or if they could put it in the chat. And if not,
Equal treatment of all people.
okay, yeah, that certainly could be a definition. What any other folks have other definitions that they want to throw out for health equity?
Well, there's one in the chat.
Okay, I can't quite see the chat.
Equal access to healthcare resources, understanding where people.
Okay. Okay, wonderful. Thanks for your participation. I really like those definitions you all have thrown out. This graphic is a way to kind of define health equity in the way that I like to explain it. So you'll see that each of these three people have access to the apples and the fruit, but it required a little bit more support for some of them. So the one on the left, you see, required 3 steps to be able to reach it. The one in the middle, 2, and then the one on the right, 1. You can imagine if the one on the left had only gotten 1 step, they may actually not be able to access that fruit. So even though they had the equal amount of support, they were not able to get equal access to the same resource. So when we think about health disparities versus health inequities, I think these definitions are thrown out a lot. And some folks may not be familiar with the differences. Do folks feel like they know the differences between them? And if so, feel free to also put that in the chat or describe it later. I'll check the chat later as well. So as you're thinking about that, I'll go through the definitions. So here, health disparities, and these are definitions from the CDC. Health disparities are preventable differences in the burden of disease, injury, or violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And then the CDC defines health inequities as differences in health status or distribution of health resources between different populations groups arising from the social conditions in which people are born, grow, live, work, and age. In this sense, health inequities are systemic differences in health that could be avoided by reasonable means. So the main difference, the way I like to think about it, is that Health inequities takes into account that there's systemic differences in health that contribute to the health disparities that are present. So it's adding on another layer of as to regarding not that there's just disparities, but that there's underlying systemic reasons why those disparities are present. So I want to also describe kind of what the ultimate goal is when we're thinking about addressing health disparities and health inequities. So thinking about inequality, so unequal access to opportunities. We know that that's present in our society, as illustrated here. One person's getting access to the fruit, the other person isn't. Now we can think about equality. So as I mentioned with the other image, you may have the same, some people may have the access to the same tools and assistance, but they still might not have access to what they really need in terms of the accessing certain resources. So thinking about equity, in this image, you can see that they have custom tools that identify and address the inequality that each person has, so they both can access the fruit, the resources. So the ultimate goal is justice, in that we'd be able to fix the system to offer equal access to both tools and opportunities. And in that way, people wouldn't need actually more support to be able to access the same resources. So in this case, you see that now the two individuals can access the fruit because now the tree is no longer leaning to one side, favoring the person on the left. Now the tree is in the middle and not favoring one person more than the other. So thinking about what are these systemic forces are, we know that there's racism obviously present in our country and throughout the world, and part of that is caused by the idea of implicit bias, which I'll explain in the following slide. And these things can be influenced by various things you can see here, such as priming, associations, and assumptions that we might see from the media or the press. This history, policies and practices that have led to, for example, the necessary enslavement of people from African countries, or just different laws that have kind of prohibited some people from accessing certain resources, or inequitable outcomes and racial disparities that are present in our country that can further exacerbate all these other assumptions and implicit biases that are present. So implicit bias is attitudes, behaviors, and actions that are prejudiced in favor or against of a person or group. And implicit bias is a type of bias that occurs automatically and it's unintentional. So it doesn't mean that someone is racist or that they have necessarily malintentions. It could be completely just automatic, and everyone has a degree of implicit bias. And it's just important to be aware of it because it could affect our judgments, decisions, and behaviors. This is an example I want to throw out on regarding implicit biases. So here, this is a figure that looked at inhaled corticosteroids that were prescribed in emergency department. And we see that certain populations had fewer inhaled corticosteroids that were prescribed in the ED compared to others. And it's the job of us and professionals in general and in the healthcare field to kind of figure out why these disparities might be present, and why there might be a different access to these resources. So in this case, it was Hispanic patients and uninsured patients that, as you can see by the confidence intervals, there was significant statistical significance in terms of having less prescriptions to inhale corticosteroids for the patients who had asthma. So just thinking a moment, why might this be? Just thinking about what about these two populations might cause them to be prescribed fewer inhaled corticosteroids. And I would argue that it has to do maybe a little bit with what we talked about in the previous slide about implicit bias. For example, we might think that certain patients may not pick up a prescription, or maybe their PCP is going to take care of it, or there's also language barriers that can make it more difficult for certain patients to get a medication or to be explained what a medication is, or a visit may take longer because of the need of an interpreter. So those are just things to think about. And then for uninsured patients, we might think about how they obviously don't have access to the same insurance that could cover these medications. But sometimes, the health disparities may not always fall along lines that make the most sense in terms of the different injustices that we see, or the systemic forces in play. In this case, we actually also saw fewer inhaled corticosteroid prescriptions for those that had private insurance, and if they received steroids in the ED. And like I said, there might not be a good explanation for this off the top of our heads. So, but one might think, why might this be? I mean, just some theories that were thrown out in this study, and were that patients with private insurance may already have good access to medication, so maybe they may not, provider may not feel the need to prescribe that medication to ED, and feels that their PCP will probably take care of it. And if someone's got oral steroids in ED, that's kind of interesting, right? Because you might think that patient's a bigger need for inhaled corticosteroid, but this study actually showed that these patients are less likely to get one in the ED. Once again, there might be a lot of factors in play, maybe time limits, because these patients have required more acute care.
Gabe, could you just, normally in a plot like this, things to the left are greater and things to
No, actually, the to the left, so anything less than 1 here means that they were less likely to have an inhaled corticosteroid prescription. So less than 1. And then, I've been highlighting the ones that have been crossed 1, in terms of the confidence intervals. And then the ones to the right, so greater than 1, would indicate that they were more likely to get an inhaled corticosteroid prescription, which in this case was if they had actually received an inhaled corticosteroid in the ED. I didn't highlight that one, but you'll see that one's actually in the far right.
Yeah,
Which
that's
is
way
interesting.
off the mark.
Yeah, way out there. And then also a SABA prescription, if they had one already, they're more likely to get inhaled corticosteroid. And I feel like that might make sense, because I also, when I was a resident in the ED, I think at that time most providers in the ED were not aware that we're moving towards using an anti-inflammatory reliever therapy for patients of asthma, and then just kind of would give albuterol. But maybe if they already have an albuterol prescription, there might be thought about what in addition to this could they receive. So that's just kind of a theory. Once again, these are just kind of theories, and just important to think about why certain patients are receiving certain medications and other resources and others aren't, when we're taking care of patients. Just make sure that we're not having implicit bias that is affecting our actions in that regard. All right, so then this is the figure that kind of looks at thinking about allergy immunology, kind of honing in now for the rest of the talk on allergy immunology. And we know that, as I talked about, structural racism is in play in terms of a lot of different factors. And it could affect socioeconomic position and cause residential segregation. So just may have less access to certain resources based on where you live. And then, of course, this affects the physical environment. So where you live affects your exposure to different environmental factors, pollutants, hazards, your housing quality. We know all this affects your health. And then there's also the social environment, like I talked about. There's different forces in play when you live in certain communities, potentially, if you don't have access to living to other housing. And we know that there's been multiple studies that show that this can cause a chronic psychosocial stress on the body, that can affect outcomes, including in allergy immunology in terms of the immune system. And this exposure, over time can just continue to grow and grow from, even pre-birth to adulthood. So this is just kind of a framework to think about how this might specifically come to play. So, for example, thinking about air pollution, like particulate matter 2.5 and nitric oxide and diesel. We know that from studies that this can affect the physiologic response and cause increased release, for example, of norepinephrine, See if I can go back in this slide. Whoops, I'm having trouble. Sorry about that. I'm on my phone, so I'm having trouble going back on the slides. But basically, that slide was just showing how the immune system can potentially be affected by stresses. And this slide just thinks about the conceptual model for achieving health equity. And part of that is research. So this just thinks about the different types of research that we might be able to do to help address health disparities and health inequities. And the first generation is kind of just detecting that the health disparities exist. The second generation would be explaining reasons for health disparities, why that might be occurring. And then third generation is providing solutions for eliminating health disparities. And then the figure on the right argues that there could be a fourth generation, which would be beyond the research and then taking action on the solutions that have been found. All right, so as I mentioned, I'm focusing on asthma today, but all these conditions that I list have different health inequities that are present. But now moving on to thinking a little bit more about asthma, so understanding the epidemiology of health inequities related to asthma. So just kind of looking at the broad general population level, all this data is going to be from the CDC from years 2001 to 2021. So I really just want to give you all a lot of numbers to really be aware of the health disparities that are present in our country specifically. Here, for example, it just demonstrates that the asthma prevalence has increased over the decades. You can see here the percent of the population that has asthma has grown from somewhere around 3% to now closer to 8%, and most recently in 2021. And then here, this is another figure to kind of look more closely in the past 2 decades. You can see that it has been a little bit more stable in the past 20 years. So the total number of persons in millions is described on the y-axis and the year on the x-axis. So overall, about 25 million or 7.7% of the U.S. population had asthma in 2021, which is an increase from 20.3 million or 7.4% who had asthma in 2001. So the overall trend still seems to be going up, but not at quite the same level as it done previously. But still, you would expect that with advances in medicine and healthcare in general, we would have a decrease in the prevalence of asthma. But unfortunately, that's not the case. We're actually having still an increase in the prevalence of asthma in our country. Looking at ED visits, though, those have substantially decreased over the years, including in the past decade. So the rate of asthma-related emergency department visits declined from 62.6 per 10,000 in 2001 to 29.8 per 10,000 in 2020. And we can think about different things that might be in play for this. So we know that inhaled corticosteroids have become used more often, and there's obviously a lot more other medications that patients have access to, like biologics. So possibly, the greater resources we're having has helped with asthma exacerbations leading to ED visits, but not the actual prevalence of asthma. And similarly, we could look at hospitalizations. So you could look at that graph here. So 13.0 per 10,000 in 2001 and down to 2.9 per 10,000 in 2020. And then deaths, which we know that is still present, unfortunately, in our country related to asthma. So it has been declining, though, from 15 per million in 2001 to 10.6 deaths per million in 2021. All right, so that's the general population. But as I've been talking about, there's certain groups that have different access to resources, and there might be health disparities present in our country. So let's take a look at that. We may start thinking about what health disparities you think might be present in our country. So to start off by just looking at the country as a whole. So what do we see here? So we see on the right, you see a range of the percent of current children by state that have asthma based on 2022 data. So I highlight there, you see on the top left, Washington, state of Washington, 7.9% current child asthma. prevalence. But you can see other states are darker in color, meaning that they have a higher prevalence of asthma in children. So we see it in the Northeast here, Pennsylvania, and then you see Massachusetts also there, is also darker colored. We see it with Tennessee, North Carolina, so down going towards the south. And then we see it more also in the Southwest, so Oklahoma and New Mexico. So once again, just thinking about why might that be? Obviously, just looking at this map, there's not a clear reason why, but you might think about why certain which populations live in those states. The access to healthcare.
Are
Sorry.
the white states zero, or they're not reporting?
Those states, I don't think they're. That may be. Oh yeah, the ones that are completely white are not available. So the data is not available. The ones that are lighter blue, like Nebraska, for example, it's just low. It's closer to zero, but it's not quite zero, just based on the data available. So yeah, so you're just thinking about what this is also thinking about potentially rural disparities, right? So we know that patients in rural areas may have less access to healthcare. So I think that might be present, might be in play here. And here we look at adult asthma. So by state, and top left, you'll see Washington State, 10.9%. So it seems like we're doing a little bit worse with the adult population in terms of asthma. But once again, there's other states, other parts of the country, and you see they're kind of some of the same states as before, the Northeast. We have, again, the Southwest, especially Oklahoma. And then we have West Virginia. So once again, things we know from the literature that rural areas such as West Virginia have less access to healthcare, and that might contribute to this asthma disparity. We know that certain populations, such as the native populations, which have a relatively high population in Oklahoma, for example, have some of the highest rates of asthma. With the Northeast, that one was a little bit interesting to me because generally the Northeast actually has relatively good access to healthcare in terms of Massachusetts, like was in the previous slide with Boston. But some of these other areas like Maine, New Hampshire, and Vermont are more rural. So I think that might be what's in play here. But it's not clear, obviously, from the data. So once again, another reason why there's more research to be needed in terms of health disparities and health inequities to figure out why they are present in the first place. Okay, so now looking at some specific groups. So here we see male and female. This is data from 2021. So what are we seeing? What are people noticing? So once again, arrows are going to be blinking at where the disparities are present. So looking at kind of the 5 to 14-year-old age group, we'll see that there's statistical significance in terms of the difference between males and females. So boys have a higher prevalence of asthma than girls do, ages 5 to 14. On the other hand, for adults, ages 35 to 64, you see that women have a higher prevalence of asthma, as well as for ages 65 and older. So once again, as the theme is throughout this talk, think about why this might be. Why is it that boys have higher prevalence of asthma, and why is it that women, older women, are having higher prevalence of asthma? And are there potentially systemic factors in play, or even our own implicit bias that could be affecting this? Okay, so then here looking at race and ethnicity. So in green, with the circles as non-Hispanic white, the black squares is non-Hispanic black, and then Hispanic is in the blue. And unfortunately, we don't have a lot of data in other ethnic groups, so that's why the data is lacking and is not present in this graph. But here you can see that the overall trend is that non-Hispanic black people compared to non-Hispanic white and Hispanic people have a higher prevalence of asthma. So you can see here 2021 is about 10% of the black population. And we know the black population in general has a higher prevalence of asthma. It has had that for many years. Looking here, though, at some other groups. So here we also see Asian and indigenous peoples illustrated. This is also from the CDC, but just kind of illustrated in a different way. And this is was also analysis done by the American Lung Association. So you can see here the indigenous peoples have the current highest prevalence of asthma at 13%. So like I was mentioning, that might account for Oklahoma having some of the higher prevalences of asthma in the country. And it's interesting, yeah, actually the Asian population has a relatively low prevalence of asthma. So you see there 4.4%. And you can see the other populations there. White 8.4%, Black 10.3%, and Latino 6.7%.
Gabe, how do you know that this isn't just genetic predisposition and has nothing to do with disparity?
That's a great question. I think the rest of my talk is going to be an argument for that it is disparities, and there's some of the in regards to social factors, but we know that yeah, genetics can definitely play a role, but we've seen more and more in other fields that genetics actually are not the main reason for differences. We've seen that in nephrology, for example, with kidney function. And there used to be a thought that it was genetic disposition for Black individuals, but in terms of creatinine also being higher for individuals with um, who were Black, we thought was that they had just natural more kind of muscle mass, right? But actually, it was found that that's not actually the reason for that, and it's not a reason to explain that. So I think we should be hesitant to say that genetic causes are the main contributor, because then that just kind of potentially gives us a reason or excuse to to not look more closely about what are the things that we could actually change in our society to help certain groups who may have not the same access to care. But
You could almost argue the opposite. You wouldn't know that indigenous peoples had a higher rate of asthma if they didn't have access to healthcare. You couldn't make the diagnosis. So by being the highest percentage,
mm,
you could say, well, they obviously had access to healthcare because diagnoses were made.
that's true, yeah. So for that specific social determinant of health, that could be you could make that argument. But there's other things that are in play. So as I mentioned, there's exposure to air pollution, your housing. So and those things can cause. We know that in terms of pathophysiology, if you're exposed to certain allergens or pollution, that could increase your incidence of asthma. And I think there's good evidence that certain populations have higher exposure to air pollution, and that's going to be a big part of the rest of the talk that I talk about in other allergens.
No, I
Let me
actually
just
agree. I agree with you. I'm just being contrarian and bringing up opposite alternative explanations.
no, I appreciate that. I definitely appreciate the discussion, and I think this is the type of healthy discussion we should be having to be thinking more critically. Because I agree. I do think yeah, not all of this data, and I showed you like the disparity with private insurance, for example. It doesn't always in terms of health corticosteroids being prescribed in the ED, it doesn't always fall into disparities in terms of a lack of access to certain things or there's actually a lot of disparities that are more in higher wealth groups, so more affluent groups, and we've seen that with autoimmune disease, for example, like inflammatory bowel disease as well, inflammatory conditions. So just something to be aware of in general, that whether it be greater or less access or just different social determinants of health can affect the health, and we should be aware of that. I did want to highlight here that Puerto Ricans have one of the highest asthma rates of any racial group. So you can see here 14% is the current asthma prevalent, and you can see the other groups here listed. In comparison, those that are identified as Mexican, 4.4%, Mexican American, 6.4%, Central South American, 5.3%. So even thinking about the Hispanic population, a group that's oftentimes categorized as just one, group, you can see that there's disparities present within that group. So just having to think about specific groups and why they may have higher incidence of asthma. And then here we have asthma rates in terms of family income. So it increases. So this is a ratio of family income to poverty threshold on the x-axis. So as you might expect, lower family income results in higher asthma rates. All right, and then here, this was interesting. So actually, patients on Medicaid have higher asthma rates, which you might expect, but it's actually even higher than uninsured patients, which I thought was interesting. And that might be going, towards the idea of that maybe these patients are just not seeing a doctor, not getting, diagnosed with asthma in the first place. So that's why the prevalence of asthma is lower in those patients. That's just once again a theory. I don't think there's been evidence to support that. All right, this is just a graphic to highlight some of the disparities that I kind of have highlighted throughout the previous slides, and you can read that later on when slides are sent out. Okay, so moving on, learning objective number 3, identify possible interventions to address health inequities related to asthma. All right, so thinking about mediators of asthma disparities and inequities. So once again, talking about social determinants of health. So if you're not familiar with that term, these are some of the social determinants of health. This includes neighborhood and the built environment, economic stability, or just economic situation in general, social and community context, education and healthcare. You can see there in the bullet points what those each mean. So we know that in general, if you have better education, better access to healthcare, live in certain neighborhoods with less crime or less air pollution, have more stable jobs and access to food. And, obviously, if you're incarcerated, you may have more inequities. So these are just things to think about that may be affecting these and contributing to these health disparities and inequities. And once again, this is them kind of listed in bullet form. I won't repeat myself, but you could just kind of read there some of the specific social determinants of health that may be contributing to health inequities. All right, so then thinking about asthma and specifically the environment. So I'm just going to focus on one of these social determinants of health, and that's going to be the environment, which we know can affect asthma risk. It could be contributed by long-term stress. And then these other factors are also in play. And as I mentioned, these structural issues such as racism can contribute to all these things. So this is an example of substandard housing as a contributor, which contributes, we know, to increased asthma morbidity. Some of these slides were taken from actually the teaching slides from the Academy of Allergy, Asthma, and Immunology. And this is one of these slides that they provide access to anyone who wants to teach others about health disparities. And in these type of substandard households, there might be larger or higher incidence or higher exposure to cockroach allergen, which we know is a major factor for many U.S. inner cities. It also depends on climate, so it's more in hot, humid areas, which is not the case in Seattle. So in Seattle, we don't have as much of this issue, but it is the case in a lot of other parts of the country, such as the South. And you can see here the different things to take into consideration regarding cockroach allergen and how it's important to remove these pests, and the different ways to consider doing this, such as sealing cracks and crevices, removal of food and water resources, and thorough cleaning. And then we also know rodent allergens are present more in these substandard housing, and higher mouse allergen exposure can worsen asthma in sensitized children. And then pest management is also important to help improve asthma symptoms for these patients. Mold exposure is something also that could be present in these households. And here on the graph, you see alternary antigen concentration in the x-axis, and then adjusted prevalence of current asthma. And overall, this shows a trend that increasing levels of the mold alternaria correlate with asthma, independent of sensitization, based on this study.
But
all right, so then
go back. That statement, independent of sensitization, doesn't intuitively make any sense.
I know, right? That doesn't make sense when we think about allergy. Sorry, I can't go back on my phone for some reason, but in terms of IG sensitization. So I think that's a very interesting, because I think that points to something else that's in play. So I think the mold is maybe not always the issue, but signifies that there's substandard housing in play, which indicates there's a lot other things in play that could potentially affect that patient's asthma. So that's kind of pointing into the fact that they may have mold in the household. They may not even be sensitized to it, but the fact that they have mold means they probably have less access to certain resources that probably affects their asthma or higher exposure to air pollution, for example.
In the chat, someone added the comment of mycotoxins.
That could be it as well. Yeah. Yeah. So yeah, maybe non-IgE mediated contributions to asthma there. Okay, so then looking at the home-based environmental intervention. So what are things that we could do to help these patients that have this substandard housing? So there have been multiple studies, and so these slides will probably look familiar because I presented on a research last year that looked at a program that's doing this in Seattle. And I'll touch on that in a little bit, but this has been studied thoroughly. So in the New England Journal of Medicine, they've shown that these sort of programs can decrease the exposure to dust mites and cockroach and reduce the incidence of asthma exacerbations and ED visits. And this also has been seen in adults through a randomized clinical trial. And like I said, the Seattle King County Healthy Homes Project was a randomized control trial as well of a community health worker intervention to decrease exposure to these indoor asthma triggers and saw similar improved outcomes. This is a program in Philadelphia. So this is looking at, this program specifically does a lot more in terms of helping these families improve their housing. So they look at plumbing leaks and they repair that to remove moisture, potential mold. They help with ventilation to remove potential nitrous oxide and other pollutants that are indoors. They help with dehumidifiers in basements, for example, to help remove moisture to decrease mold and dust mites, and so on. So I won't go through all this listed there, but you can see there's a lot of potential interventions that could be done in this this group in Philadelphia did this program, and you can see here some of the before and after photos of the repairs they did with leaky plumbing replaced, for example, and bathroom renovations. And then they had some improved outcomes, like I mentioned, for this study specifically. You can see here that based on the p-value, the significant difference in system-free days in terms of days over the span of 2 weeks. Also, caregiver quality of life scores were better for the people that were in the intervention group for that study. And in general, we know that reduction of in-home asthma triggers lead to decreased healthcare utilization. So here you can see that it says parental report of in-home asthma triggers before and after repair. So specifically, it looks like for those that had cockroach and rodent issues, before and after repair, there was decreased healthcare utilization. And then oh, sorry, the level on the left was just more about triggers. So for cockroach and rodent, it seems that the parents reported an improvement there for their children. And on the right, you'll see is decreased healthcare utilization that was described before and after repairs. So in general, this can have a positive impact in terms of our overall use of resources in our country. Okay, and this is just going to go through this part quickly because this was what I presented with my research, but I just wanted to show you that we do have a similar program here in Seattle. It doesn't go as in depth. It doesn't have as many resources as the one in Philadelphia, but if you have patients that have asthma that's poorly controlled, there's this program that you could have 3 home visits and phone call follow-ups with community health workers. And then they just have to be ages 5 and up, in King County resident, and have poorly controlled moderate persistent asthma. And the criteria for that is having impaired lung function at baseline, or 2 or more ED visits or hospitalizations in the past 12 months, or daily symptoms or impaired physical activities by appropriate medical therapists. So check out the King County Public Health Seattle website, and you'll see you should see a form to be able to refer patients to this. And if you don't see it, then you feel free to reach out to me, and you can help your patients in this way. And this is some of the inspections checklists that the community health workers have here in King County. All right, so moving on, thinking about air pollution. So I know it started late, so I'm going to try to go through some of these slides, and I may skip through some of them. So air pollution, we know, is a mixture of particles and gases emitted directly into the atmosphere. Um, and then we know climate change has been affecting things in general. In the US, about greater than 40% of the population live in areas with poor air quality. And in terms of the world population, at least 90% live in areas with poor air quality. And this affects not just asthma, but obviously other conditions as well, including cardiovascular disease. So these are some of the sources of air pollutants. We have natural sources such as wildfires. Bioaerosols can contain volatile organic compounds. And there's anthropogenic industrial causes as well, and as well as transportation, agriculture, land use, dwelling, and domestic causes of air pollution. And then I won't go through this slide detail for the sake of time, but this slide kind of summarizes some of what was in the previous slide. So according to the WHO, by 2050, approximately 50% of the world's population will have asthma and or allergy at least once in life, and air pollution is a primary risk factor for that. The things to think about regarding air pollution is nitric oxide, ozone, particulate matter 2.5, black carbon, and the studies have all kind of shown that these contribute to new onset asthma, particularly in adulthood as well with chronic exposure. And there's a correlation between poor asthma control and elevated particulate matter 2.5, as well as pollen severity. A meta-analysis of 26 studies that was conducted worldwide found that 4.8% increase in risk of asthma-associated ED visits and admissions among children exposed to short-term increases in particulate matter 2.5 of at least 10 nanograms per metric or meters cubed. And we know even short-term exposures, though, can affect and cause increased mortality related to asthma. This is an example of how this might play a role here in Seattle. So you can see here, this was provided by that Seattle County Healthy Homes Project. And I get this image specifically from Dr. Jim Stout, who's a pediatrician that helps lead this. And you see this in the study that there's increased incidence of asthma related to hospitalizations and ED visits among children who had Medicaid insurance, who lived near the 5 interstate highway. You can see here just illustrated with the density level on the right. So areas in red had higher incidence of asthma-related hospitalizations and ED visits. And you can see that they seem to congregate around the I-5, not entirely, because you see up in the north, there's not as much red. And it seems to be more in the south. So, and we know that there's certain populations that live more in the south because of, for example, higher cost of living in Seattle over the years has caused a lot of folks to move down south. So I think that's one explanation for the data you see here. All right, and then we know that climate change can have an impact as well on asthma. You can see here some of the causes that global warming, extreme weather conditions such as wildfires and air pollution can cause and contribute to asthma. For the sake of time, I won't go through all of them in detail. Here you see that this was looking at change in risk in terms of having these different conditions, and I'll just focus on asthma. So for asthma, you can see that it had the highest change in risk percentage. All these or several of these conditions, including all respiratory conditions, have a change in increased risk, but asthma had a lot higher increased risk in terms of exposure to air pollutions. All right, and then thinking about, like I mentioned, that term of justice earlier, so environmental justice, so it would be addressing environmental injustice, which is the disproportionate exposure of vulnerable groups to environmental hazards like the ones I've described earlier. Once again, this could be affected by all sorts of social determinants of health, such as those that are illustrated here. Okay, so thinking about strategies to help reduce impact on patients with asthma and allergic diseases in regards to air pollution in particular. You'll see some here. So obviously just educating our patients about minimizing their exposure, just being informed of the local air pollution and allergy levels. And then using N95 masks can help, especially when air pollution is high. And then so on. These are a lot of things I know that we're aware of, but we may not always take the time to educate our patients regarding this. And then, so thinking about at the higher level, so what are things that could be done at the community level and also governmental level? For example, there could be more urban planning to have more green spaces, which we know can help reduce um, carbon greenhouse gases, which could improve outcomes for patients that have a higher exposure to air pollution. And then just improving the knowledge of these triggers and interventions in general at the community level. In terms of governmental regulations, there's different things that could be done to reduce air pollution and increase access to healthcare. Here are some examples of policy interventions that have been effective. So, for example, in 1996, the Olympic Games, there was a initiative to have reduced traffic near competition venues. And from that reduced traffic, there was an associated reduced ED and hospital visits for asthma during the time of the Olympics. So you can see even with a short period of time, the 2 weeks of the Olympics, having reduced traffic near the competition venues led to reduced ED and hospital visits for asthma in populations that lived by those venues. There's also reduction in pollutants that have been occurring in California. And there's reduced emission for respiratory tract infections in children that's been found because of this, and improved lung growth in children in high exposure areas with pollutants when they were reduced. And in North Carolina, there was the Clean Smokestacks Act, which reduced pollutants, specifically particulate matter and nitric oxide, and that was shown to have reduced incidence of asthma, emphysema, and pneumonia. Okay, so then going through lastly, the last learning objective, identifying how allergists may partner with the community to help address health inequities. So just a summary before I go through how we could collaborate with the community. This is a summary of the health inequities. Just as a reminder, there's asthma prevalence and severity that are higher in Black and Puerto Ricans when compared to non-Hispanic whites. And there's also this similarly for the indigenous population, though there's less lacking data for that. And asthma death rates are actually higher as well in adults, women, and non-Hispanic Black people. And we talked about the different mediators of asthma inequities that may be present. So ways to address asthma disparities and inequities. We could think about community school-based asthma education and management programs, telemedicine, web-based programs. Like the main example I illustrated, environmental allergen mediation at home, but also at school. We talked about precision medicine, and we talked about how there can be genetic factors in play, but thinking about making sure that we're using that precision medicine to help certain groups that they may have those genetic and epigenetic predispositions. Policy changes, such as environmental justice, as I described, and other social determinants of health, and addressing those. And this is kind of a graphic to highlight kind of what was talked about in the previous slide in terms of the community level, provider level, policy level, and the patient level. And as an allergist, immunologist, we have different ways that we could contribute. So first would be just recognizing these health inequities are present. And I hope that today's talk helped in part with that. Identifying multi-level determinants impacting health inequities, and partnering with all these different groups to help address these issues and providing education to these groups as well. And we know that more research is needed for these historically marginalized groups. So these are some things to consider for those researchers out there. So increasing and actively recruiting members of underrepresented groups for specialty in general, and recruiting and maintaining diverse investigators, recruiting diverse subjects who are representative of the research goal, providing adequate and equal compensation for all subjects, make more grants available directed at addressing health equity, providing mentor of new investigators, and engaging underrepresented communities in all aspects of the research, from design to publication of results. And just a couple other things to think about. For example, just highlight the middle one, developing patient-reported outcome measures relevant to these communities is something that could be considered. Okay, I'll skip this one for the sake of time. But I just want to highlight something you could do now that you probably all are doing, but maybe not doing with every single patient. So the asthma action plan, I think we're all familiar with that, talking about what inhaler a patient should use when they're in the green zone, when they're doing well, or when they're having symptoms, or when they're having severe symptoms. It's important, and this study shows why it might be important. So the asthma action plan was actually found to help reduce oral steroid use and exacerbations for children. You see here that outpatient oral steroid use based on the p-values were significantly lower for children 3 months after, 6 months after, and 12 months after having an asthma action plan provided. And then any exacerbation was also lower in those timeframes, 3 months, 6 months, and 12 months. And then I'll just skip through this, but you can look at this later in the slides. This I thought was a really nice meta-analysis that's described through this graphic in terms of different interventions that could be done to help with asthma. So we know that these different factors are in play, increasing access to healthcare, increased caregiver self-efficacy, quality of life. And there's home environmental trigger reduction programs that I talked about. These all can help reduce reductions in asthma for ED visits and hospitalizations. All right, so skipping through that, here's some summary interventions you can look at later. And then once again, the word of the day was equity for those that were here to listen to this talk. And if there's any questions, I welcome them. You can put them in the chat. Actually, better to email them so I could look at them later. And just want to leave you with this quote. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Dr. Martin Luther King, Jr.
Gabe, thanks very much. I have one question. I'm just curious if anybody has looked at asthma rates or prevalence or asthma death in nations that are much more homogeneous to places, say like Iceland or Norway or Switzerland, which to a certain extent just remove a lot of these inequities in society?
That's a great question. I didn't look into that into detail. I really focused just in the U.S. when I was doing this presentation. But I'd be happy to look into that because I'm also curious about that. I would imagine that there would be differences in certain countries, even despite the fact that they have more homogeneous populations. I imagine that some of these social determinants of health would also affect them, and they would also probably have disparities that are present related to asthma. I think that has been seen, but I just don't have I can't say for sure because I didn't really look at that data for that.
Yeah, I'd be interested in that. I mean, a lot of these countries are racially homogeneous and have better healthcare systems than we do. As far as everybody being, in a socialized healthcare system where they don't have to pay, because money drives almost everything you were talking about.
Right.
All right. Any other comments before Gabe wraps up? All right. Thank you all. Next week, as I mentioned, will be in person and back at South Lake Union at the request of faculty and fellows.
Len, I don't know.
Hello.
Yeah, go ahead.
Gabe, are you there?
Yeah. I'm here. Yes, I'm still here.
Sorry, Vinod Doraiswamy here. Sorry, I know we almost passed the time. So one big question is, I know earlier we had someone present a really good talk on asthma. What is asthma? So in the context of how asthma is defined, how much do you think there's an issue in terms of data when things that are asthma are not asthma and things that are asthmatic are not called asthma in terms of interpreting this data?
That is a really great question. I didn't come across that as I was doing this talk. Besides the fact that I did show data that all respiratory conditions are affected by air pollution, the diagnosis of all respiratory pollutions, and specifically they were looking at emphysema as well. Bronchiectasis actually seems to be higher in people that have higher exposure to air pollution. So this does seem to be something that kind of affects all respiratory conditions in general in regards to air pollution. And that's possible. Yeah, I do think it's possible that some of these populations maybe have higher incidence to those conditions. We definitely know, for example, For example, the native population, like in Alaska, has a higher incidence of bronchiectasis. And potentially, yeah, maybe some of those patients are being diagnosed as having asthma, but they actually have something else like bronchiectasis, because they have higher incidence of immune deficiencies, for example, in the native populations. So yeah, no, I think that's a really good point. Yeah, it's something I'd be curious to also look more into and see if that might be the case.
Thank you.
You're welcome.
Gabe, thanks very much. We're a little over our time, so other questions, go ahead and send them directly to Gabe.
Yes, feel free. Great. Thank you, everyone. Thanks for listening.